Good afternoon, everybody. My name is Harendra Vijay Sundar. I'm the Vice President of Medical Devices and Clinical Intervention here at CADTH. On behalf of the CADTH CEO, Dr. Brian O'Rourke, and our entire team here at CADTH, I'd like to welcome all of you to this afternoon's webinar, our Evidence to Action series on home dialysis in Canada. Before we get going, I'd like to acknowledge that today's in-person session in Ottawa is being held on the traditional and unceded territory of the Algonquin Nation. For those of you who aren't familiar with CADTH, we are an independent non-for-profit organization that brings evidence and expert recommendations to decision makers right across the healthcare system on the optimum use of pharmaceuticals and medical devices. We launched our Evidence to Action series to highlight areas that are of particular interest and relevance to Canadians. It's hoped to be a venue to bring together policymakers, clinicians, and patients so that they can hear directly from researchers and also clinical experts on what the evidence is and, importantly, what it means. So today, this afternoon, we're going to be looking at the appropriate use of dialysis in patients with end-stage renal disease, and specifically concentrating on home-based modalities. For those of you who haven't been able to look at these recommendations, they can be downloaded from our webpage at www.cadth.ca. And you'll also find other interesting links for both clinicians and providers. So let me take a few minutes to set the stage. End-stage renal disease is a highly prevalent issue. Latest data from the Canadian Institute for Health Information, CADTH, shows that there are over 40,000 patients with end-stage renal disease in Canada. About 60% of those patients are receiving dialysis, and the majority of those are in institutions. So today, we're going to focus on home-based modalities, both hemodialysis and peritoneal dialysis, which is used less frequently. And as a spoiler alert for those of you who haven't looked at the recommendations yet, what we found was that these home-based modalities are as effective as those in the institutions, but importantly provide clinicians and also patients with more choice and as cost savings to the system. So today we've put together an outstanding panel of both patient advocate and nephrologists from the Ottawa Hospital and also two CADTH staff who are intimately involved with the report to walk you through what the evidence is and what it means. I'm very proud of the work that CADTH has done in this area. I think it fills an important gap and will provide important information for all of you in your everyday decision making. For those of you who are here and those of you online, you'll have the opportunity to ask questions afterwards, and for those of you here in person, there'll be an opportunity to meet with panelists informally afterwards. I'm proud that this is an area of lots of interest, and there are over 500, almost 500 people who are part of this webinar, both in person here and online, both in Canada and in other places across the world. So with that, I'd like to please join me in introducing the moderator for this session, Effie Hillis, who's a Knowledge Mobilization Officer here at CADTH. And over to you, Effie.
Thank you very much, Dr. Vijay Sundara, for this kind introduction. Good afternoon, everyone, and again, welcome to our Evidence to Action event on home-based dialysis. Today, we will share the findings of the evidence review on home-based dialysis, but more importantly, we will see how the evidence relates to clinical practice, and even more importantly, we will see how the evidence relates to patient experiences. We are truly delighted today to have with us Mr. Kirk Kelly, who has very graciously accepted our invitation to share his experience with kidney disease and dialysis treatment. Mr. Kelly's story is truly one worth listening to, so we will invite him shortly to introduce himself and describe his story to us. Welcome, Mr. Kelly. I would also like to welcome Dr. Manish Sood, a nephrologist at the Ottawa Hospital. Dr. Sood is an assistant professor of medicine at the University of Ottawa, scientist at the Ottawa Hospital Research Institute and the Institute for Clinical Evaluative Sciences, deputy editor-in-chief and founder of the Canadian Journal of Kidney Health and Disease, and he holds the Jindal Research Chair for the Prevention of Kidney Disease. Dr. Sood has kindly accepted our invitation to share his clinical experience and offer an insight into aspects of clinical practice when it comes to home-based dialysis. So questions like, what makes a successful home-based dialysis program? Who is a good candidate for it? Dr. Sood has also contributed his expertise and guidance at several points during the project. Welcome, Dr. Sood. Dr. Alison Sinclair, our clinical research officer who led the review of the clinical evidence, will provide us with an overview of the approach and main findings of the CADTH review. Welcome, Alison. And after those presentations, I will review with you issues that may influence the effective uptake of home-based dialysis, and we will review ways in which CADTH can collaborate with decision makers across the country to facilitate the implementation of home-based dialysis. So our goal today, or what we would like to accomplish, is first of all to increase awareness about the evidence and recommendations among a variety of decision makers in home-based dialysis. We will hear about the real life and real practice perspective of the evidence in use. We're hoping to initiate a conversation around home-based dialysis options in Canada, and increase awareness around support options from CADTH for those interested in implementing home-based dialysis. I will make a parenthesis here just to say that this is a social media friendly event. You are encouraged to tweet and follow tweets throughout the session. Please use the hashtag CADTH Talks or hashtag dialysis. And as we have already heard, there will be an opportunity for questions from our in-person and online audience after we have heard from our panel. And just a few instructions here. So for the online questions, there are 3 steps. So step 1, please click the participate button on the webcast player, then enter your email address and write your question and hit send. And for those participants in the room, before asking a question, please turn your microphone on. It's in front of you so that online participants can also hear you. And also a kind request to all participants to please identify yourself and the organization you represent when asking questions. So with no further delay, I would like to invite Dr. Sood, who will provide us first with a very brief introductory overview of kidney disease and dialysis treatment in Canada. And after that, Mr. Kelly will take it from there to describe his lived experience with the disease and the treatment. Welcome, Dr. Sood.
So thank you. Thank you for the introduction and the offer to speak today. If my name looks a little familiar, it's because my wife is a covert agent that has infiltrated your organization. She is a CADTH employee, Amy Sood, and if any of you have had the chance to work with her, you'll realize she's quite talented and intelligent. I just want to temper expectations here and just mention that she's definitely the better half. So with that, let's start. And really what I'm going to be discussing is kind of a dialysis 101. Everybody may not be familiar with the terminology we use, so I'm going to go through some of the terms and definitions, as well as give a brief overview of some of the data regarding dialysis care in this country. So I don't really have any competing significant conflicts of interest. I do have funds from various agencies, including pharma, but nothing that would be viewed as directly conflicting what I'm speaking with today. So let's begin. End-stage kidney disease is defined as life-threatening kidney disease and kidney failure such that if you do not receive dialysis or a kidney transplant, your life will be shortened and or you will die from this condition. We term dialysis plus kidney transplantation, we term this renal replacement therapy. In other words, it's replacement, renal being the word for kidney, it's replacement of your normal kidney function. There's a whole variety of conditions that cause your kidneys to fail in this country. Hypertension and diabetes are the main ones, but there are many others as well. So in this diagram, what I'm trying to depict is the paths that you may follow once you require renal replacement therapy. So first off, some patients may not even choose to have dialysis or renal replacement therapy at all. Their kidneys may fail, and for whatever reason, they may be elderly, they may have said, I've had a good life, I'm not even going to go down this path at all. They're not going to even choose to enter any of these treatments, and that may end in premature life for them. But those that have or choose dialysis therapies can choose essentially two major branches. One, they're going to choose to have their treatment essentially at home or their place of residence. Conversely, they can choose to have it in some form of a medical facility. Now, the medical facilities can be things such as most commonly a hospital or an ambulatory care center, but they can be a bit diverse as well. They can include, for example, some nursing homes, and they can be even located in commercial spaces such as strip malls. We have a dialysis unit in a strip mall in Ottawa. So from the at-home therapies, there are a few options. And these include something called peritoneal dialysis, which is a special type of dialysis that's done through your belly. I'm going to speak and show a little bit more example about these as we go on. There's something called short daily dialysis, hemodialysis, which is a dialysis that's done through the blood, again, done at home. And then there's a procedure called nocturnal hemodialysis, where patients actually hook themselves up to a machine at night, sleep while they're being dialyzed or their blood is being cleaned, and then they wake up in the morning and or disconnect. On the other side is something called the intermittent hemodialysis, which is our most common form of dialysis that's performed in this country. It's performed usually, as I mentioned, in a medical type facility where patients come for 3 times a week and spend about between 3 to 4 hours per treatment in a hospital bed or a hospital chair receiving the dialysis treatment. It requires nurses, it requires physical space and usually a hospital, and trained specialized staff to do that procedure. Anytime in this pathway, if you are on the home dialysis therapies and you run into medical problems or complications, you can be switched to the intermittent hemodialysis component. Conversely, sometimes people on intermittent hemodialysis can choose to go to home dialysis as well. So there is a lot of dynamic movement between therapies. But most of the time, patients who start on the intermittent in-center hemodialysis route do not often switch the other way. All of these patients are, if medically suitable and if an organ is available, able to receive a kidney transplantation. Just some pictures to kind of illustrate what I've been discussing. So up in the top left corner, this is peritoneal dialysis. And what happens here is patients infuse a dialysate fluid into their belly. There's a permanent tube that sits inside the belly. And this fluid goes in, sits in the kind of free spaces in the abdomen, and through kind of a high school chemistry diffusion procedure, what happens is toxins that build up in the blood go against their concentration gradient, enter this dialysate fluid, and then are drained out of the body at a later time. In Canada, there's 2 ways to do this. The 2 ways are you go up and hook yourself up to these bags and let the clean fluid come in and let the dirty fluid go out 4 times a day. Or you can hook up to a machine that does these exchanges for you overnight. The majority of Canadians who do this procedure do the machine at night type. The next procedure we're illustrating here is nocturnal hemodialysis. Here, patients can go to bed. They actually have a machine, a dialysis machine given to them. Special piping and plumbing work is done to improve their water quality to make it medically safe. And they actually hook up to the machine through their blood flow, so they might have to involve putting a needle in their arm. And then they sleep while the machine is on, and they do this for any period of time, 6 to 8 hours. Similarly, patients may be in the comfort of their home and be doing this while they're awake. It's not restricted that you have to do it while sleeping. It's based on their preference often. And in the bottom, we have the kind of classical, most commonly done in-center hemodialysis, very medical, very kind of, you can see many patients in one room, hospital beds are involved, and patients come in, have their treatments performed, then go out and another shift of patients come in and then have their treatments performed. So in Canada, if we have a look at some trends, this is data from the Canadian Organ Replacement Registry, which captures data on all dialysis patients in Canada. And this is data from 2006 to 2015. Excuse me, on the y-axis we have the percentage. And this is, I want you to make two observations here. This is at least trends over about a decade of data on the prevalence of patients with end-stage kidney disease. The top bar, the red bar, which has slightly been declining over time, is this classic in-center, 3 times a week, expensive hemodialysis therapy, and it's the highest. The next is patients who have a successful working kidney transplant, and that to us is a success story because those are the patients that essentially do the best. Lower down, the green bar is peritoneal dialysis, as I mentioned, hovering anywhere between 10 to 15% of all patients who require renal replacement therapy. And the home dialysis, which is still emerging, is lower in the 2.5% range. Now, what I'm going to do in the next slide is I've removed transplant out of the picture, and I just want to focus on dialysis alone. So if we focus on dialysis alone, it's the same figures, but I've just removed the transplant patients. You really get an understanding of how common this in-center 3 times a week dialysis is. It's really taking up almost 80% of all treatments in this country. Slight decline over the last decade, but again, it's slight. Peritoneal dialysis plus home dialysis has hovered around 20 to 25% and really hasn't risen significantly over the last decade. We're always interested in geographic patterns on dialysis. Even though in Canada we always say we're one common universal healthcare system, the reality is the way funding is, it's dispensed individually to provinces and they can choose to do whatever they want with it. So patterns of how it is being done across the provinces is a big interest of mine. What I have here is geographic territories divided up by the type of renal replacement therapies. What you see are some interesting and distinct patterns that I'd like to spend a second talking about. If you look on the far left, BC has a very high transplantation rate, and then the second last province or region on the right, Nova Scotia and PEI, also very high leaders in renal transplant. Conversely, if you look at Nova Scotia and PEI's home hemodialysis, it's very small. Same with their PD. So it's interesting to look at that, and you can speculate maybe the patients that are on home hemodialysis are very healthy, they get transplanted right away, so there's few patients to remain on those home hemodialysis therapies. That's a possibility. But other observations you may be able to look when you see this is there's quite a bit of variation on the use of the red bars, intermittent hemodialysis in hospital across the country, with lows coming in Ontario, BC, and Alberta, and highs in Newfoundland and Manitoba. Similarly, you see large variations in the patterns of home dialysis therapies across the regions. So some kind of bullet points over and about dialysis in Canada. Both the incidence and prevalence are rising, and they've risen about twofold over the last 20 years. So this problem is not subsiding. In fact, it's going to get worse. When we look at projections and population demographics, this is going to continue to rise. At present, there are 36,000 Canadians, at least as most recent as 2017 core report, who are currently on dialysis therapy in this country, and the majority of them are elderly. Over half of them are over the age of 65, and survival, although been improving over the last 2 decades, is still very poor. Many people don't think of this dialysis in this way, but the survival is worse than most cancers. It's worse than breast, it's worse than colon, it's worse than almost every cancer except lung. 44% of patients who start dialysis survive greater than 5 years. It's expensive. It's an extremely expensive therapy. This population makes up only 0.1% of the Canadian population, but 1.2% of the total health expenditures. So they're really using up a lot of resources, and they need a lot of care, rightly so, but it is a very costly type of treatment. As well in Canada, compared to other regions, we have little national oversight. So a lot of other regions have dedicated data programs to study dialysis, to look at trends, to implement knowledge translation activities and CQI, continuous quality improvement programs, to try to optimize the way they deliver their care. They have much more advanced programs in the UK, USA, Australia, New Zealand, and Europe than we currently do in Canada. We have little oversight, and we really just hope that each province is doing the best they can and things are going to work out in the end. Lastly, and I'll look in the mirror for this one, compared to other subspecialties, nephrology has the lowest quality evidence. And a lot of that is because we have very few high-quality RCTs. And there's actually studies showing, comparing us to gastroenterology, oncology, cardiology, we're by far the lowest. And because of that, the evidence base that we have for making our decisions is poor. And I'll go into in the second half of my talk what it means when you have a poor evidence base and how this can lead to a lot of practice variability. So with that, I'd like to take the chance to introduce Mr. Kirk Kelly, our patient advocate.
Thank you, Dr. Sood. Good afternoon, everyone. I'd like to thank CADTH for giving me this opportunity to speak with you this afternoon. I have been on a walk with my kidneys for about 30 years, I think 29 years and counting. I'm 64 years old, just had my birthday a few weeks ago. Yeah, the kids were all good to me. I've been married to the same girl for 44 years. I have 2 kids. I'm a big hockey coach, and I've been in the mentoring of young people, young men specifically, in the mentoring business with a couple of Canadian universities and a couple of junior hockey teams over the last several years. I started dialysis in 1988, although I did have some kidney problems as a child and as a senior in high school. I have a complicated history of medical history, and you'll hear in my story that I've had some kidney transplants as well. When I was young, I had about 15 years from the time I was around 10 till through a senior in high school and onward. A number of repeated kidney infections, and I had renal hypertension. The kidney infections simply were, a change in the color of my pee and an opportunity to get some antibiotics, and usually a 10-day course, and I was sort of back in business. And I thought little of it as a child, little of it as a young man growing up. In 1988, I had been promoted at work and was told I needed to have an insurance policy taken out on me. And when I went to the doctor to have the blood work drawn, his results were, you should see a nephrologist, your creatinine is elevated. It was elevated so much that within 6 months I had started on dialysis. In 1990, I had my first kidney transplant. I was hugely optimistic, returned back to work, I think within 5 or 6 weeks of being transplanted, and could see nothing but blue sky. In 1995, unfortunately, the kidney failed. I must tell you that I didn't know that kidneys failed. Yeah, my kidney had failed, but I thought that a renal transplant meant you had the green light and you were off you were to the races, and so off I went. Yeah, it succumbed to a cytotoxic reaction. I was having difficulty with my drugs, obviously, and it was quite a shock. I think I was a little bit more than disappointed at that happening. But in that same time, I had to restart on dialysis. It took a few months before they removed that kidney transplant, but I did start on dialysis. But I decided that I wouldn't go back to the hospital environment, and I decided to go to a satellite center that was located at Yonge and Sheppard in Toronto, and it was sort of kind of on the way home from work. So I could go on Tuesdays and Thursdays after work, and on Saturdays, I typically went on Saturday mornings. So I was a 3 times a week, 12 hours a week patient, and I went on that therapy hoping that things would work out. Unfortunately, I wasn't the most diet compliant guy on the planet. If you know anything about about kidney failure, you go on a special diet, and there are lots of do's and don'ts, and I did most of the do's and almost all of the don'ts as well. So I ended up having some pretty significant problems with my blood calcium, my phosphorus levels, and my parathyroid hormone in my body, which is controlled by a couple of the little glands that are in your neck. Started to cause additional problems for me. I developed calcium deposits on my hands and on my feet. This is an example of a calcium deposit that grew on my right hand. It's about half the size of a golf ball, and you can see that it has it scabbed over there in the middle, and that's because they spontaneously burst open and you begin to leach calcium out of your body. It's a kind of an unpleasant thing. The one on my hand was really unpleasant because it was the hand that I shook hands with, and so I was in business, and of course you shook hands with someone and that immediately got the conversation onto another topic when you really wanted to try to sell the guy something, if you'll excuse the expression. But the ones on my feet were worse. The ones on my feet got in between my toes, didn't let me get my skates on anymore. Eventually I couldn't get my shoes on even, and it's tough to do business in sandals and socks. So that was a pretty poor experience. Let me digress a moment and think about the first time on dialysis. When I was told I had end-stage renal disease in mid-1988, I got to tell you that I really stopped listening as soon as somebody said end stage. Because as a patient who had little or no information on kidney disease, end stage meant end stage of what? And I really thought I was perhaps going to die. I was sort of unwilling, unable to really process this idea of being chronically ill. There were no pre-dialysis clinics in those days. I was a short window to start. This all happened in about 4 or 5 months. So even if there were pre-dialysis clinics, a good chance I might not have been able to go to one. I followed my physician's advice unquestioningly. I wanted my doctor to tell me what to do. He did, and I did. And I went into a sort of learn-as-you-go environment. The first time I saw a kidney machine was the first night I went to be dialyzed. So I had little or no idea of what was going to happen. And I went on the transplant list, as you already know, because I had my first transplant that I discussed. Life on dialysis is not so great, and I will counter this in a few slides, but life on dialysis is great, so indulge me that I'm doing it backwards. When you're at dialysis, and especially if you're in the in-center dialysis in the hospital, the first thing you begin to develop is a sense that you really don't want to be there. Even though we can all internalize how we feel, we always feel better than we think the guy in the next bed is. And when you look over, you think to yourself, there's way too many sick people in here. What am I doing here? There were so many new things happening. I think there's a lot of fear. Fear of the unknown is probably the worst. The patient who doesn't know what's going on, hasn't had an opportunity to get that shared with them. The 4 hours seem to go forever. And so therefore, at 3.5 hours, all you really want to do is go home. The renal diet, I talked a little bit about me not being a very good renal diet guy. But if you had to take 15 Tums with every meal that you ate so that you could bind up the phosphates, you wouldn't probably want to be eating too much, or you wouldn't want to eat the right things. I dreaded monthly blood work because there was always a debate between myself and my primary care nurse about why my blood work was so horrible. One of the symptoms is that you get a terribly itchy skin when you're on dialysis because of your blood chemistry. And there's not much you can do about that. There's no really relief therapy, if you will. You're almost always tired, and I really felt that I wasn't myself. I was not coping well with everything. I don't think that I was coping well with life. Certainly life at home had changed significantly. I felt that I had lost my status at work. I'd lost my self-esteem and my value to my family. Things that were all very important to a type A personality who wanted to do the best he can no matter what it was that he was doing. Dialysis patients have a saying of whether or not they dialyze to live or live to dialyze. And I got into that particular aspect of therapy at that time. I felt that my life revolved around going to dialysis. It may be 4 hours on the machine, but it takes an hour to get there from the office. It takes an hour and a half to get home after your dialysis is over. So you're investing 6 or 7 or 8 hours a day on dialysis days. On the day after dialysis, you don't feel like yourself because you're pretty washed out from the event from the previous day. So you're actually living every day just to get back on the dialysis machine. I went through with all the classic symptoms of being chronically ill. I denied it. I wanted to be angry. I wanted to bargain with myself. And over a decade, I came to a reluctant acceptance. I chose to go on home therapy when the calcium deposits began to get so debilitating that I couldn't do the things that I needed to do at my work and in my sports job. And the doctors told me I needed more dialysis. Because of all the things I just mentioned, I couldn't imagine that I could fit more dialysis into my life. I was already too busy to do dialysis as it was, and I couldn't make that mental bridge that I was going to have to do more. In the late November of '98, I heard about nocturnal dialysis from a fellow patient, someone who I had bumped into in a bakery, who I knew that had dialyzed for years at the same center that I was, but he had gone, he had disappeared. I wondered whether he'd been transplanted, maybe he was more ill and couldn't do dialysis at the center. But what he said to me was, "No, Kirk, I have gone on a new therapy at night." And so that caused me to apply for nocturnal dialysis. I found out who the physician was, Andreas Paratus at Humber River Hospital in Toronto. And I started and was trained in February of 1999, and I went home in March of 1999 and started nocturnal hemodialysis. The setup at home, a kidney machine. Dr. Sood talked about the kidney machines in your bedroom. There's a relatively small footprint. There is a water system involved, a reverse osmosis water system that purifies the water. All of your dialysis supplies are delivered to your home, so you have to have space for that. I set up a special room down in my basement, and I could store about 30 days of dialysis supplies down there. The delivery company was fully accommodating, and the delivery man would take the dialysis supplies downstairs. You didn't have to do any heavy lifting or lugging. And there was a ton of support, both internal and external. The external support is probably most important. The technicians and the nurses at the home dialysis unit were available to you 24/7. If you had a problem with the machine or a problem with yourself, you could talk to a nurse, and if it's the machine, you could talk to a technician. I dialyzed at home for almost 14 years, and I never missed a second night's dialysis because of a hardware problem. So the machines are hugely reliable. There are some economic impacts for patients because the dialysis uses a lot of water. Most patients see about a 50% increase in their water bill. You'll also notice a marked increase in your hydro bill as well, because the machine, obviously, while it's running, is using hydro. So both of those are noticeable, and in some cases, for some patients, are significant, especially patients that don't have the financial wherewithal to be able to absorb those decreases in costs at home. I know there are initiatives being investigated by the Ontario government to help compensate people that receive medical treatment at home, but to date, none of that has come to fruition. Life on dialysis is great. Well, now that we've started on home dialysis, when I first started, I wanted to find a dialysis that would fit my lifestyle. I needed to cut down on the wasted productive time. At least that was my thinking at the time. I felt that on conventional dialysis, my health was slipping away. I had gone through a significant amount of problems with my calcium deposits. So I encouraged all of us to think that we need to seek advice and we need to advocate for ourselves. As patients, there's no question that should go unanswered. Nocturnal dialysis fit my life perfectly. I received dialysis 6 nights a week, 8 hours at a time, or 48 hours of dialysis a week, as opposed to the 12 hours of dialysis a week that I was getting under conventional treatment. There's a direct correlation between the amount of dialysis you get and how you feel. And so therefore, I felt very, very good. I was worried about bringing dialysis home because I thought it would encumber my family somehow. But I found out that the people at home love you a lot more than the people at dialysis do. And so therefore, you make an easy transition to home dialysis. One of the great misgivings of being at home is that you have to be your own advocate for going on the machine every night. And so therefore the dialysis police also exist at home. Your daughter, your wife, and your son are all saying, Dad, don't you miss dialysis tonight because you know you're going to feel bad tomorrow. And so therefore you have some internal incentive to make sure that you stick to your prescription. You know, I think that the change in my life started when I really began to realize that I was dialyzing so I could live as opposed to the other way around. And as I've already said, no one does it alone because my family was such a great help. Some of the benefits of home therapy were increased energy and stamina. I'm a big golfer, like to play a couple times a week. I can walk the course. A decrease in medications. As I got on more and more a long time on home therapy, things like blood pressure medications went away. A lot of other medications that I had to take went away to the point where I was really just taking a multivitamin every night, and that was what I needed. There's no renal diet, which for me is a lifesaver. There's no renal diet when you're on nocturnal hemodialysis. In fact, the dietitian asked me, do you think you can eat more? I said, I'll work on it. Because they want to make sure that you're being well nourished and your hemoglobin is staying up. No more itchy skin. Actually, the picture of health. I think I've talked about some of these other things. The fog is lifted. Many dialysis patients complain about the fact that they feel impaired in their cognitive skills. I became my old self again. My wife coined the phrase, Kirk became the man he used to be. I felt physically stronger. My family life was renewed. And all of my passions came back to my life. Here's my hand. That is exactly 10 months after I started on home dialysis. The calcium deposits on my hands look impressive, but the ones on my feet were even more impressive, how quickly they cleared up. I was able to go back and do things I like. There I am at the cottage fishing. The fish was very cooperative that day. I love hockey. I love young men who are involved in the game. I've been involved for 30 seasons. You know, I just want to give some accolades here to nurses. One of the things that patients do is they develop a relationship with somebody in the dialysis team. In my case, the primary care nurse became the person that I could go to get all of my answers. If you want to be happy on dialysis, make a friend of your primary care nurse. A comparison between conventional and nocturnal dialysis. I think I've talked pretty much about conventional. You know, I had difficulty with my diet. I had poor blood work. I had some other issues with my blood chemistry. And those all somewhat over time normalized when I was on nocturnal hemodialysis. So I was most importantly to me, though, that it was a lifestyle choice that allowed me to reduce the amount of productive time that I needed to spend while doing dialysis. So my days were my own, and I could concentrate on my work and on my family life. I am currently transplanted, so therefore I've just drawn this up to give you some idea of how I feel about conventional, nocturnal, and transplantation as far as the kind of drugs you take, your body weight, the blood tests, the amount of time that it takes, your sleep, my activity, my emotional state, and vacation. Dialysis patients are always concerned about vacation because dialysis on the road can be difficult from time to time. And so when you're transplanted, that becomes a non-issue. In the summer of 2001, and the living is easy, my friend Ian from England and myself at the deck at the cottage, everything was looking great. I had a second kidney transplant in September of 2001. I was on my way to Peterborough to a hockey game. I got a phone call that I had to be at Toronto General by midnight, and I got a kidney. Unfortunately, it was an unmitigated disaster, and the kidney was diagnosed immediately after being transplanted as having something wrong with it. Acute tubular necrosis is what ATN stands for, and the kidney did not start. Survived about 5 months while getting dialysis. Eventually, they removed the kidney. I returned to dialysis, went right back to nocturnal dialysis, felt well quickly, but then started a decade of issues with my health. I had to have my right native kidney removed. I tried to clear my body of the hepatitis C virus, which I had contracted during my first kidney transplant. That seemed to go horribly wrong and affected my heart. I suffered a cardiogenic shock. Once I survived that and got better, then I developed a stridor in my airway because I'd been intubated for so long, ended up having a tracheal resection, which had to be redone. Spent 90 days in ICU at Sunnybrook Hospital trying to make that work. But I was very fortunate that I had a new lease on life because in December of 2013, I got a third kidney transplant, a live donor kidney from my son. I'm 47 months post-op. I'm happy to report excellent results. My creatinine is probably better than some people in this room. My expectations are high, and I continue to advocate for others. Quickly, some perspectives on 29 years. Nocturnal dialysis was extremely effective for me. Not all patients find it extremely effective for them. Some can't sleep. Some can't handle some of the things that are involved with nocturnal hemodialysis from a maintenance of the machine standpoint. Some don't even get used to the noise of the system running, and they have to go back to some other treatment, some other renal replacement therapy. For me, I think that it's probably keeping busy is the key to success for me. My faith gives me hope, and I continue to advocate for others. Takeaways are assume nothing, always ask questions, strive to make sure that every person feels involved and valued. Make sure that person-centered care really starts with information and education. I don't believe that anybody can learn too much about what's wrong with their body. Make sure that patients feel empowered. I think the decisions regarding your modality, deciding your choice of treatment, have to be made collaboratively with the patient, his family, and with the caregiving team. My current priorities are pretty simple. I live each day to its fullest. I love to volunteer, not only just with the CADTH and with speaking, but I also am a peer support volunteer with the Kidney Foundation. I sit on the Patient Advisory Council at Humber Hospital in Toronto. I'm also on the Ontario Provincial Patient Advisory Council at the Ontario Renal Network. I volunteer with York Regional Police, and I also love to travel. I spend a fair amount of time at the cottage, but I like to get down to the Caribbean every winter. I have new grandkids. The oldest one's 3, the youngest one's about a year and a half. So they're my full-time joy, and I enjoy them so very much. Thanks for listening. I appreciate it.
Thank you so much, Mr. Kelly, for sharing this great story with us. We really look forward to hearing more from you during the discussion part of this session. I would like now to invite Dr. Alison Sinclair, our lead for the clinical review, to guide us through the evidence and the main findings of the CADTH review. And then Dr. Sood will follow again quickly to give us a glimpse of how this evidence is put into action when it comes to offering and providing home-based dialysis to patients. Welcome, Alison.
Put that well out of the way. Thank you. I'm going to talk about the clinical and economic review we conducted at CADTH, plus a separate review of end-stage renal disease in Indigenous patients. So we expanded the policy question into 4 research questions, comparing the clinical effectiveness and safety of the home dialysis modalities, home hemodialysis, or peritoneal dialysis, with hemodialysis carried out in a dedicated hemodialysis unit. And we defined home broadly as being the patient's residence, which included long-term or residential care or prisons or jails. The second question concerned the clinical effectiveness and safety of home hemodialysis compared with peritoneal dialysis, therefore the 2 home hemodialysis modalities. The third question compared the various prescriptions for dialysis. Dr. Sood mentioned short daily and nocturnal hemodialysis, and we compared them with the conventional schedule for hemodialysis. And finally, since we were interested in the effect of assistance, we looked for comparisons of in-center hemodialysis with assistance by a healthcare worker compared with in-center hemodialysis done by the patient themselves or by a trained caregiver who was not a healthcare worker. We carried out a systematic review. We recruited with studies with adults over 18 years who had end-stage renal disease requiring dialysis. And they could be requiring dialysis either as a lifetime because they were ineligible for transplant or had declined transplant, or while awaiting transplant. The primary outcome was patient quality of life, and we had a fairly long list of secondary outcomes of importance in dialysis. We were interested in comparative studies, so we looked for systematic reviews, randomized controlled trials, and non-randomized controlled studies. For our primary endpoint, for home hemodialysis or peritoneal dialysis versus in-center hemodialysis, we found a small amount of evidence. The systematic reviews included cross-sectional data. And one randomized, so we did not, there is something I forgot to mention, the strategy. In the interest of not duplicating previous work, we adopted the strategy of we started by looking at the systematic reviews. Did they or did they not answer the question? If they answered the question, we used a systematic review and then updated it with the newest studies. If they did not answer the question, we did our own primary review. So with the quality of life, we did our own primary review, found a small number of studies. There was no consistent difference in the primary outcome of quality of life, but there was a lot of variability in the way that the studies adjusted, in the measurements that they used, the standardized measurements they used, and in the time points at which they measured it. For the secondary outcome for our first question, 3 systematic reviews had looked at the comparison between home hemodialysis and in-center hemodialysis, and then 4 recent primary studies had been published since the last systematic review. Now, the 2 systematic reviews had included 2 small clinical trials, but neither of them had the power to detect a difference in survival. And as Dr. Sud mentioned, trials in dialysis tend to be few, and they tend to have a challenge in recruitment because once patients are fully informed, they have a preference about which treatment they receive. So much of the evidence is non-randomized, and in a non-randomized study, the factors that influence the selection of a given dialysis modality may influence its success. And there are modern statistical methods that can adjust for differences in patients, but for that you have to have measured the covariates. So the risk of confounding it always remains. And so there's a qualified finding that for an appropriately selected, motivated patient, home hemodialysis may offer a survival benefit. And then there were the questions about whether older patients may benefit less, patients with comorbidities may benefit less, and then there was a lack of evidence around race and gender. We had more data comparing peritoneal dialysis with in-center hemodialysis. The majority of studies showed no difference in overall survival, but poorer survival for elderly patients or patients with comorbidities. And patients on peritoneal dialysis were more likely to switch to in-center. For the comparison of home hemodialysis with peritoneal dialysis, we had 2 systematic reviews, and they were updated with 5 primary studies. And in those studies, neither modality had a clear advantage in survival or hospitalization, although home hemodialysis patients, again, were more likely to switch than peritoneal dialysis patients. When it came to looking at individual prescriptions, we had 3 primary studies that were all registry studies. There was no definitive evidence to favor any prescription except for the observation that more intensive hemodialysis might lead to better survival. But this was in a small subset of highly selected patients. And finally, we did not find any available evidence comparing self-care and assisted in-center hemodialysis. So moving on to our limitations, We did not find clinical studies on rural or remote settings or in home settings other than private residences. We didn't find clinical studies on the effective assistance. Studies on peritoneal dialysis versus in-center hemodialysis predominated, and other comparisons were less well represented. We didn't have much information on comparative quality of life, and studies were almost exclusively non-randomized, and although many were large and well-done registry studies, you still had the risk of confounding, because although they collected the clinical covariates well, there were not the socioeconomic and the system covariates available. The economic review was intended to address the comparative cost effectiveness of different dialysis modalities across different delivery settings, for example, urban, rural, and remote. We intended to conduct a cost utility analysis, and that would allow simultaneous comparison of both the costs and outcomes of each treatment strategy. But as the clinical review didn't find high quality data, a cost analysis was conducted instead, and that largely ignored the clinical outcomes and focused solely on costs. But that acknowledges that, at a patient level, there may be clear individual preferences for specific modalities. We conducted the economic analyses both from the user-payer perspective and from a societal perspective. And conducting it from a societal perspective allows for better understanding of the patient-borne costs associated with certain forms of dialysis, and whether potential costs are shifted from the healthcare system to the patients and caregivers with home hemodialysis. So from the perspective of the payer, lifetime costs range from $560,000 to $840,000, with the least costly strategy being home hemodialysis on a conventional schedule. Home-based therapies, and these included peritoneal dialysis and home hemodialysis, trended towards being less costly than in-center therapies. More intensive, more frequent or nocturnal in-center hemodialysis was substantially more costly than any other dialysis modalities. The cost differences were even greater in the rural or remote settings because of the greater cost of in-center hemodialysis in that setting. When it came to the societal perspective, home-based therapies are associated with lower patient travel costs, but potentially significantly higher home utility costs and less reimbursed. And in Canada, most of these costs presently fall on the patients. Although there's a potential gain in terms of home and workspace productivity with home-based dialysis, this should be interpreted cautiously as there's wide uncertainty around the measure's productivity. Now, according to 2015 estimates, Indigenous Canadians had up to 4 times the rate of end-stage kidney disease, and at the same time they're less likely to see a nephrologist. When we realized that the criteria of the main search, which was mainly the requirement for comparative studies, was filtering out studies that involved Indigenous patients, we did a separate supplementary review in the form of a rapid response with peer review. They found 7 studies with mixed results. Indigenous patients tended to be younger, to have more comorbidities, and were more likely to be female. They had higher mortality rates than white patients, but once the rates were adjusted for those comorbidities, the difference disappeared in all but one study. There wasn't any information on home hemodialysis, but Indigenous patients were less likely to start peritoneal dialysis, to switch to peritoneal dialysis, and they had greater rates of PD failure. Telehealth turned up as a possible vehicle for support in remote communities. Given this, an additional point that came out of the review with the need for culturally appropriate delivery of healthcare at all stages. So screening and prevention, education and appropriate care, particularly given that they're younger end-stage kidney disease population and the higher rates of technique failure and lower PD use. Thank you very much, and I will hand over to Dr. Sood.
Thank you very much. So, excuse me, thanks to that excellent product and summative report from CADTH, we're now in a unique position where we have something substantial at a national level. And the question that I'm now going to attempt to address is, how do we take this back to the bedside? How do we apply this in clinical practice? And how do we make policy recommendations in regards to these findings? So the first question you can ask yourself is, as a clinician, how do we decide who goes on home dialysis? And the answer is, it's tricky. And the reason I say that is because there's no evidence-based standard of eligibility. So as I mentioned in the last, my very last slide from the first part, when you don't have an area with good quality evidence, you are susceptible to a high level of practice variability. In other words, people do what they've been taught to do, what their grandfathered to do, what their successors or predecessors did. So that's what they do, what they're taught to do. Because of that, you'll see local practices have home dialysis believers, non-believers. There's some people in nephrologists who are very adamant about it. They're local champions, and these people will significantly influence care. We previously did a study, or I was involved in a study, where we looked within one group of 20 plus nephrologists and found huge variation in one group alone, with some people barely referring anybody for peritoneal dialysis over a many-year period to some referring as high as half of their population. So we were seeing large degrees of variation. How about at the national level? If we were seeing this at one group, we went one step further and said, let's study, excuse me, getting over a cold. We went one step further and said, what's happening at the national level? Is this variability measurable? So we looked at peritoneal dialysis utilization across Canada, again by regions, and we found large differences in the proportion of PD use, as I kind of illustrated earlier, across provinces. And it was a total of 16% absolute difference when you went from leaders like big cities like Toronto and Vancouver to where we are right now, Eastern Ontario and the Ottawa region. And we found this interesting, but you can easily say, well, you know, Toronto may have a different patient population than we do. We have some differences that maybe they're sicker here versus there. So we even went one step further and did modeling where we attempted to adjust for these factors, and these things still remain. So what I have here is a hopefully recognizable map of Canada, and what you can see is greater than 1 is a higher likelihood of being on peritoneal dialysis. Less than 1 is a lower chance of being on peritoneal dialysis after we adjusted for all recognized patient factors and some facility treatment factors. Again, Vancouver, Toronto, 50%, 1.5-fold higher use of home dialysis or peritoneal dialysis compared to us in Eastern Ontario, Northern Alberta, and even in the Atlantic provinces where we were using considerably less. So really what we're seeing here is that local championing, practice patterns are making a huge influence on how patients are being selected for or directed towards home dialysis therapies. Furthermore, there are other intrinsic factors that we found. This is a recent study that we did where we looked by race. And what we found here, this is peritoneal dialysis in the left, home hemodialysis on the right. And what I'm going to try to focus, this is different races, Asian, Black, Indian subcontinent, Indigenous or Aboriginal peoples, and other category. What we found is consistently home dialysis therapies, either PD or home dialysis, were less likely to be utilized by Indigenous peoples. And that almost seems contradictory or counterintuitive because often Indigenous peoples are living remotely from urban centers, would have less access to in-center dialysis, would likely be maybe potentially even more likely to go towards home dialysis or home-based therapies. A couple of other things that have been tried through the last few decades in Canada and other jurisdictions with variable effects. One of them that is successful and is more widely needed is, of course, detection and early prevention and screening of kidney disease. This is kind of a no-brainer, but it's crystal clear that if we're able to detect people with kidney disease earlier in the course of their illness, either we can prevent them from progressing at all, or if they are going to progress, we can give them more education. But there is also some contradicting evidence to that point. One of the major proposals we made to try to help clinicians understand kidney function better, because there is some intricacies in interpreting it, is we started something called eGFR reporting. What that is a standardization where we report the percentage of a patient's kidney function to the ordering physician, so that there is no maybe gray area of interpretability. You would think that this would improve early detection and then get physicians to perhaps have more time to educate people to do home modality therapies. But in Australia and New Zealand, they actually did a very nice study with a time series and showed that this did not influence peritoneal dialysis rates, which was a bit of a surprising finding. Other things that we can try to do, we can implement clear guidelines and referral pathways to get patients to nephrologists as quick as possible. Again, most regions in the country have these things worked out and are being actively done. And we have seen that there are other studies that have contradicted perhaps the Australia and New Zealand study that have showed getting patients in the hands of nephrologists early can allow us some forms of increased education and improved home dialysis. How about financial incentives? Physicians are unfortunately like everybody else in some ways, and we can be incentivized by finances. In the US, they have recently, it used to be that nephrologists would be reimbursed higher for in-center classic hemodialysis 3 times a week than they were for home dialysis. The idea is that perhaps there's more work involved in taking care of these people. They're here 3 times a week, so we'll pay you more for that. So in the US, they recently increased the financial reimbursement for home dialysis to match in-center, and it has resulted in about a 2% increase in their home dialysis use. They were very low to begin with, so really they had nowhere to go but up. This similar strategy was done in Ontario in 2007, and it didn't change anything. So we didn't see any bump there. So again, contradictory, not clear, things have been attempted, but they haven't really made a large headway to changing our home dialysis use. How about internationally? So this is where things get really interesting. So this is a nice study that is showing, sorry about the small print, different countries and their proportion of peritoneal dialysis use for all the patients on dialysis. Canada is the middle bar. Roughly in this time period, it was 18% of our dialysis population was on peritoneal dialysis. You could see again, US, very low, 7%. As I said, there were a lot of financial incentives to not use peritoneal dialysis. It wasn't being done. But then you see some interesting things in Hong Kong. Hong Kong is probably the largest developed nation who instituted a peritoneal dialysis first policy across the board. And what you see there is a 70+% utilization of peritoneal dialysis. In other words, they created a scenario where the choices aren't occurring at the level of the physician and the patient. They just said, we believe in this, it's cost effective, we think it's got equal outcomes, this is the way to go, let's do it across the board, and unless people fail it, that's the way we're going to go. And they have maintained very high home peritoneal dialysis rates. In the interest of time, I'm going to skip through this, but this is kind of showing similar data. Now, I want to come to this because this is a very interesting study. What this was done by a group in Alberta, and what they did is they went to dialysis patients who were, they did live remotely, and they had to relocate to get their hemodialysis therapy. And then it kind of went back to them and asked them, if you could trade survival, in other words, could you trade years off your life to go back to the community of the place that you originally were and stay and reside in your community, If that's possible, how much would you trade? And the average respondent replied 4 years of life, to be back with their home, their family, and their community. Offhand, I don't know how many of these patients were Indigenous. I suspect there were a lot. And the interesting phenomenon was it was age-related, so as patients got older, they were willing to trade more years off their life to be where they wanted to be. Sometimes physicians and patients, there's a disconnect with our wants. And sometimes the physicians focus far too highly, I think, on things like mortality and hospitalization, where in patients there may be a large discrepancy in what they want. And I think this reflects the importance of making moves that they're happy with, patients are accepting of. This is the most recent costing work that we have seen. This was just presented at the American Society of Nephrology, and this was done a little differently. This is cost per year, and it's a cost minimization study. What this showed was intermittent hemodialysis had a roughly cost of around $64,000 per year. The major drivers of this cost are staffing, the nursing staff that is required. You have ratios of nurses of roughly 1 nurse to every 2 patients, from anywhere to 1 nurse to every 4 patients. If you have a hemodialysis of 30 patients that's running 12, 14 hours a day, you can imagine the cost. Peritoneal dialysis is just over half, $38,000. Nocturnal hemodialysis, $39,000. Newer technologies of nocturnal hemodialysis, where the machines are smaller and more user-friendly, but the machine is more expensive, also more cost-effective. Building rural satellite in-center hemodialysis units ranges anywhere from 100 plus to 200 plus per quality adjusted life year. It is a difficult proposition to create, to maintain. When you make very distant rural northern centers, it's very hard to maintain staff in those centers as well. They simply don't appear to be a cost-effective strategy. And when you look at these costs, it varies by time. So for example, nocturnal hemodialysis, the costs are often front-loaded because you're buying the machine, you're setting up the watering and the water purifiers, where the in-center hemodialysis is kind of a consistent rising cost over time. So the question comes again, how do we increase home dialysis utilization? Here we have this excellent product from CADTH saying or stating that the outcomes are similar and if not better for patients on home dialysis. But really, I showed you the trend over the last 10 years. It hasn't budged above 25% for home dialysis utilization, despite these things we've been trying. So I'm putting forward a bit of a challenge with, is it time to think completely differently? Do we have to abandon what other countries have been doing with these thoughts and try to do something uniquely Canadian on our own to try to bring that up to, say, 40%, 50%? And this is really some controversial, possibly radical ideas that hopefully could set the bar higher. Should Canada become, if not the first, the second developed nation to set a home dialysis first policy? So instead of seeing people and letting a judgment take place at 2 levels, the physician and the patient, should we just assume that home dialysis is the way to go and build everything around that? Build supports around that and let it be that is the way they're going to go unless we can really find a reason to not have them go home dialysis. Other proposals that can be built around this that might be a little more practical, because I do think that that's a hard thing to institute across the country, a home first policy, but things that can be a little more sizable or easy to implement would be stop building satellite hemo units. They are cost ineffective, they're difficult to provide staffing for, and really, if you do live in a rural residence, even based on the data that we're asking patients about, would they be willing to give up time or potential elements of their health to stay in their community, home dialysis should be the first modality for people who reside rurally. How about there are areas in this country where dialysis growth is occurring so rapidly that they're not able to build hemodialysis units quickly enough to put the patients in it. And that's mostly a lot in the prairies, maybe in northern BC. And in those areas, should we, instead of trying to put in all the capital expenditures to building new dialysis units, start looking at home dialysis first policies. Not only is cost containment, but we now have the backing of this product saying and showing that essentially the outcomes are similar. Lastly, a large component of our dialysis units are the elderly. A lot of them live in long-term care. 50% of the elderly patients over the age of 70 or 80 who start dialysis will need a change in whatever life, wherever they're living residence-wise, will need a change in that residence. So I'll give you an example. If you live at home, within 6 months, 50% will need to live in a retirement home. Those who are living in a retirement home, 50% will need a nursing home, etc. That was shown in a very nice study in the US. So really, if we know that a lot of patients are going to end up in long-term care facilities, shouldn't we focus on home dialysis for these facilities? Then you get economies of scale where you say have a home nurse going to help them with their dialysis, but there's many patients in that home where it can be done for them at the same time. These policy changes should be coupled with other things that are occurring in the background, and one of them is technological shifts. We are getting smaller machines that are easier to use. There is, in the distant horizon, the ideas of having a wearable kidney. This technology is being tried out. It may be a decade or so away, but these things are coming. Lastly, and we didn't touch on it, and it's a little beyond the scope of the product, is kidney transplant is by far the best thing to do for anybody who has had kidney failure. It has the best outcomes, the best lifestyle. I think Kirk really articulated it much better than I ever could, how great kidney transplant is. And I think we should look towards a presumed consent policy for organ donation. It has worked well in countries like Spain, where it has increased organ donation tremendously, and I think this should be something seriously on the board. So, we have a repeated slide here. Okay, I've already talked about most of this. So with that, we went a little bit over, but I would like to thank you for the opportunity to speak today. Effie, are you going to say some final words? Yeah, okay. I'd like to have Effie come back up and take it from there. Thank you.
Thank you very much, Dr. Sood, for this great clinical overview. I appreciate that we are a bit over time, and I am a little stressed about that, I have to admit. But having said that, I know that our speakers previously touched upon a lot of the implementation issues that I wanted to talk about. Having said that, I think I will very quickly indicate that our CADTH review also included a review of implementation issues. And we do know that some of you who are listening to us today are considering the implementation of this option in your organization. And some of you may have set target numbers that you want to reach by a certain timeline. So the CADTH review examined implementation issues that relate to home-based dialysis through a review of the literature and consultations with dialysis stakeholders across Canada. And we continue these consultations across Canada as time goes by. So we have identified strategies that are being currently used across the country. I will just show the slide very quickly with an indication that a copy of this live stream event will be available on our project page at cadth.ca/dialysis. We identified barriers at the different levels of decision making, policy, funding, organizational level, and of course for patients, we identified things such as fear of failure of doing treatment on their own, negative bias towards treatment, lack of interest to move a medical setting into their home and burden their family, cost concerns, particularly when reimbursement policies are not in place for these patients, housing issues, and social support. We did a review of considerations and barriers and facilitators when it comes to patients living in rural and remote settings. And for those patients, having access to this type of treatment is very important. In some cases, they have to relocate from their place of residence to be closer to treatment. In other cases, they refuse treatment altogether. So we identified challenges related to that, as well as things that could facilitate the implementation of home-based dialysis for those settings. And a big one here is the availability and use of telehealth for patients to have access to nephrologist care and consultations. Finally, I would like to, we heard about the evidence and our recommendation. As I said, we're hearing more about issues and things that we should be considering when it comes to home-based dialysis. So recently, we heard from some stakeholders, things to consider are that many different professionals are involved in renal care and that frontline medical staff need to be buying into this model. We're hearing about the importance of pre-dialysis care and nurse training, as well as the role of nurse educators. From patients, we're also hearing that many patients feel isolated when they are in home-based dialysis. Again, about costs. And finally, in home-based dialysis, caregivers need to be knowledgeable and reliable partners in care. So, coming to the end of this, I think that in general we can say that the shift in current dialysis community culture and infrastructure requirements must be in place to support home-based modalities. And CADTH is committed to support the recommendation from our expert committee by providing or supporting education to appropriately address existing knowledge gaps at the various levels of healthcare decision-making and facilitating connections with stakeholders across the country to share successful strategies that already happen. And as you better understand your local barriers and you identify opportunities for improvements, CADTH resources are available for supporting implementation of home-based dialysis, and these include specific knowledge mobilization activities, development or adaptation of tools, and approaches to fit specific context and patient population needs. I wanted to let you know that we're here to facilitate connections with either national groups or other stakeholders in jurisdictions across Canada. And I would like to invite you to visit our page at cadth.ca/dialysis, where you will find more information about the report, about the implementation issues review that we didn't have much time to talk about today. And you'll find science reports, summary tools, as well as other resources and educational tools from Canadian and non-Canadian networks and renal groups. I would also like to invite you to connect with the liaison officer, the CADTH liaison officer in your area to explore possible opportunities and implementation support options. So I think I would like to end this as it's something that Alison said the other day when we were discussing about this presentation, and I think it captures the essence of the project and home-based dialysis quite well. The fact that home-based dialysis is right for the right patient at the right setting with the right support. And with that, and before we open it to questions, I would like to, first of all, thank the speakers for their time and the valuable information that they shared with us today. I would like to thank the CADTH team for their support for this event, and I would like to acknowledge Dr. Jihad Nesrallah, who has been extremely generous with his time, not only during the project, but also after the completion of the project. And it is because of him that we got connected with Mr. Kelly. So thank you very much to all. And I think with no further delay, we can open the floor to questions, and hopefully we can have some brief conversation about home-based dialysis. And just a note that our colleague Gino De Angelis, he will be handling the online questions, and we will try to alternate between in-person and online questions as much as possible. Thank you very much.
This question's for Alison. I'm Alan McDougall from the CMPA, and I was curious about, in the health technology assessment, did you take into consideration organ donation as an alternative technology to peritoneal dialysis? Yeah.
I think mine's B, actually. No, we did not. The question specifically concerned dialysis modalities, and we excluded transplant. We had transplant as an endpoint. You know, we looked for some. We did try and find out whether transplant affected the eventual outcomes, but no, the modalities we were interested in were the dialysis ones. I
just maybe in follow-up was curious, maybe if anyone else on the panel wanted to respond, but you know, what if a great investment was put into making living donation, for example, more, what's the word? A better incentive maybe for patients and their networks to seek out. Just curious if anyone's doing any work on that or if you had any reflections.
So I'm not a transplant physician, but and I'm not sure exactly where the status of it is, but there has been discussions about things as simple as reimbursing living donors for some reasonable incurred costs due to the procedure. There's some trouble, though, that gets into any further reimbursements of costs, as you can imagine the scenarios that can arise from that. But I think living donors are one angle, and I'll give you a scenario for living donors. If you think of ESRD rates, they're 4 times higher in the Indigenous peoples population, and that population, 40% across this country, are younger than the age of 25. So the wave is coming. And if you look at living donation in that population, it's very challenging because you often have, and these are, I'm speaking in generalizations, large families where many of the family members are affected by the same condition. So living donation becomes very challenging in those situations. Another way, at least not referring to living donation, is this idea of can we increase deceased donation? Because that's where really the bulk of organs are. And the presumed consent is, I think, the biggest way to go. Again, I'm not an expert in the area, but it had made large changes and large increases in transplant rates and organ availability in Spain. And whether it could do the same here, it would be a question of interest.
So just a question online here. This one's directed to you, Dr. Sood. So thank you for your presentation. Any idea of additional cost variation, so in regards to water and power bills for patients across Canada?
My personal experience was that the water and power requirements for most patients was notable. In my particular case, my water bill went up by 50%, so that if I was getting a $200 a month water bill, I was now getting a $300 a month water bill when I was on home hemodialysis. Similarly, I didn't see the same kind of increase in hydro, but there was a marked increase, 7% I believe it was, increase in my hydro bill for the years that I was on home hemotherapy. Whether that, and I'm an Ontario Hydro customer, I know that hydro is regulated by different utilities across the province. So I don't think there's been any definitive studies on this, although my work at the Ontario Renal Network tells me that it is something that has caught the attention of the Ontario Renal Network, and being able to compensate patients for utility costs is something that is being discussed and is top of mind there.
If I can add to that, other jurisdictions do also provide compensation. Some of the newer technologies require less water. So some of the newer, smaller machines require less water. But I look at that as low-hanging fruit, the ability to get that at a reimbursement, than the attempts to shift the dial to get more people to home dialysis. I think that's the major hurdle where I think most jurisdictions wouldn't be reluctant to compensate those small amounts versus the large costs of in-center. And even you could take it one step further. Aside from that cost, as I mentioned, physician reimbursement's a big deal. And most jurisdictions have now moved to somewhat equivalent physician reimbursement for the different dialysis modalities. But again, why not even look at making more reimbursement for home dialysis? Instead of making them even, why not try to put a financial reimbursement or incentive for physician reimbursement to increase home dialysis utilization? I just think that we have to start throwing a lot more ideas on the table if we're going to budge from 25%. Thank you.
Maybe I'll ask a question. First, I'd like to reiterate what Effie's thanks to all of you for really a great set of talks. My questions to you, Kirk. I was moved by the powerful arc, your story over 30 years. And I note that for a lot of that, you were your own advocate for pursuing home-based dialysis. And all of you, in all of the talks, there was mention of culture change. And so I wanted your reflection of, over this time period, has that culture change started, or is it occurring both with providers but also patients? Are they getting the tools they need to help with this is a preference-based decision to some degree?
Thank you. I believe that there is a dynamic change taking place in kidney care, certainly in Ontario where I live. The decision-making process for modality choice has gone from a dictate to a selection, if you will, a menu of selections for the type of treatment that patients might be able to do both either in center or at home. Shared decision-making as a model has been well established and is used at the Ottawa Hospital with all patients that are in the CKD, chronic kidney disease program. And the shared decision-making allows patients not only to investigate all of the different types of modalities, but to then do some positive matching with their desires. And it takes into consideration things like lifestyle, and it takes in their own capabilities. And it's an ongoing conversation during the time that their kidneys are failing, so that when they have to eventually start on dialysis, they make an informed decision. I think that that's significantly different than it was when I started on dialysis 30 years ago, and they were chipping the kidney machines out of stone. But now the patient has a much more opportunity to embrace dialysis that works for him or her, and I think that that's a key issue. And that collaborative approach can start at the beginning, and I think it goes through the entire process of being on dialysis, including making the dialysis or the renal replacement choice of having a kidney transplant.
So going back to online, another question here. So with the shift to more home-based dialysis, and specifically PD, what role do you see rural hospitals taking to support these patients in their communities?
Thank you for the question. If we are going to institute some of these policies and start moving in these directions, serious consideration has to go into how we're going to support these. And we can't just immediately switch a whole generation of people from one therapy to another and just let them fend for themselves. And I think the benefit is in this country, we have a decent experience with peritoneal dialysis. You know, we have 20%. We've been doing it for 40 to 50 years now. So a lot of the problem solving and expertise, the problem solving's been hammered out and the expertise is there. The question is resources. So, for example, if you are going to put people in more rural environments, you're going to need support networks there. Things like you can establish local hubs. So, for example, a central reporting region where a bunch of rural patients have a go-to for care and help. You're going to have things like telehealth and availability of nephrology expertise 24 hours. It is possible, at least when I worked in a previous lifetime in Manitoba, we covered the entire province. So we had patients that were so distant that they had to fly in on a plane. But we were able to successfully cover them, and through phone calls and through the support of 24-hour available access to us.
Thank you very much. I think we're almost just about out of time. So I would like to take this opportunity to, again, thank you all for participating in today's session. We hope that you found this information helpful. We really look forward to connecting with you in the near future. So please feel free to check our website, our dialysis page. We will be sending out a link to a feedback survey shortly, so please let us know what you thought of the session. And here are some upcoming events that CADTH is hosting in the near future. We hope that we can see you there, but please be in touch. And thank you again, and have a great afternoon, everyone. Thank you very much.